kind of open discussion on the use of implantable defibrillators. I'm sure some of the biophysics and basic scientists will feel a little bit embarrassed finding who is having to have a defibrillator, but it's good to have this opinion. So for the clinicians, because we have basic scientists also in the table, so I would like probably to put it in two stages. And one is we clinicians, we do not have other good means to treat these patients rather than prevent sudden death, because the particle defibrillator is not treating anything, but simply preventing the consequences. So we need from you some information whether we'll be able in the future to do something more intelligent than simply planting the defibrillator, which is very rough and non-intelligent therapy. So we need to know whether in the future we'll have real support that genetics or new drugs will be available and produce a cure to the disease. And then for the clinicians, of course, we need to know whether we agree or not which patient should receive the device right now. And I think that we all will immediately agree on the patient that has been recovered from psychotic death. I don't think anyone of us would question this. Because the patient has had the psychotic arrest, the probability of having the second one is high. If he's not protected, the probability that he's dead, that he will die is very, very high, because there will be no second option for him to be recovered in the majority of cases. For syncope, we have been discussing a lot on the real value of real syncope, identifying what the real syncope is, to make sure to make the difference between vagal or irrelevant symptoms, for the patients were before about vague symptoms and real syncope. And then, of course, we have the asymptomatic patient as a patient that we have a lot of doubts, and we should try to understand it. I don't know whether someone want to enter in these two discussions.
Does anyone in the audience have a particular case that they wanted to ask us about?
Let's maybe Peter talk about the introduction. Yeah, which
Sure.
probably is the extreme complex.
Sure.
If we solve the problem in children, if we agree in children, we'll agree in the rest for sure, because children is the real nightmare for you, for me, for all the people that has to take care of these type of things. What's the approach?
So ICD implantation in children is a very difficult topic. One is age limitation, space limitation. Dr. Brugada, I think it was yesterday, showed a picture of an infant with an abdominal device implanted with, I think there were 3 coils in the pericardium. And this type of hardware is not uncommon in the neonatal patient with an ICD. So you have to have a very good reason to put an ICD. And I'll give you an example of a patient that we were following. It was a baby that was born with long QT syndrome, had several episodes of torsades, was defibrillated externally about 30 times before they even came to our institution. And once they arrived, we put this patient had pseudo 2-to-1 heart block. We put the patient on isopril and did pacing, temporary pacing at first, and the patient's rhythm stabilized. But we had a hard time deciding whether we can send this patient home without a defibrillator. So what we hemmed and hawed about it, but ultimately what we decided to do is send the family home with an AED, and we informed the patient and the mother that though implanting an ICD was possible in this scenario, we thought that it probably wasn't the best thing for the patient. And the patient actually had on the pacemaker that we implanted permanently, had several episodes of non-sustained torsades that self-resolved. Presumably, if the patient had an ICD, they would have been shocked for each one of these episodes, because most of them last for more than 30 seconds. So it's never an easy decision in a pediatric patient. Conversely, when it is an easy decision, it's a kid that's older than 10 that has veins that will house a ICD safely, that had a sudden cardiac arrest in the past that was documented. That's the opposite extreme. We had a case like that last week, as a matter of fact, that 15-year-old hypertroph that arrested while he was at recess playing basketball. So in those patients, it becomes much easier. But everything in the middle is really a long conversation and has to be very appropriately stratified.
Yes, because we haven't talked about that. What's the role of left hysterectomy in this patient?
It depends on where you are. I think at the Cleveland Clinic, for instance, it's not a common practice to perform them, though I know in Boston and at Mayo, they're performed pretty often. I think the roles are in any catecholinergic arrhythmia, so long QT certainly in CPVT. In CPVT, I think the role is probably more appropriate than any other arrhythmia syndrome, only because CPVT, there's such a high risk rate, such a poor symptom improvement with beta blockers. Some patients get experience a lot of improvement with beta blockers, but others have no symptom improvement actually whatsoever. So flecainide is next, and if flecainide doesn't work, then stelectomy is a pretty good option for those patients.
We have quite a good experience with left hysterectomy in children, very, very small children, neonates with torsadas, with storms with torsadas. And our results are pretty convincing, and now we are probably considering, for sure, we are considering left hysterectomy prior to any implant in this population, for sure. I mean, implant is being, especially for the energy, I think implant is a very bad option.
Potentially bad, right?
And certainly we always would go first to left hysterectomy before implanting ICD. Always. Now, we will not implant a patient with catecholinergic without prior trial on left hysterectomy, which has a very good result. But you need the adequate surgeon.
Yeah, that's right.
Really knowing what he's doing. And it's very simple surgery, but he has to be very knowledgeable that he has to eliminate all the connections to the heart. Some questions from the audience? Comments?
I have a question. I guess when you see a patient, for example, in the emergency room or whatever, and ECG suggests a type 1 Brugada, you will do EP studies for all of these patients as to risk stratify them? Is that okay?
Again, is that an asymptomatic patient?
Asymptomatic.
For
example, a patient.
Spontaneous type 1 ECG?
Exactly.
Yeah, we'll do that. Sure. Certainly.
Basically, this was addressed in the by Prof and the previous presentation, and it is always a challenge basically, because those asymptomatic patients, their first presentation could be a sudden death. So I think EP study in type 1, manifested type 1, is quite appropriate to do an electrophysiologic study on those patients to risk stratify them. If they are inducible, if they have negative study, then this is reassuring. If it's positive, then we have to speak with the patient about implanting a defibrillator.
Sure. I think, and that's something that I see quite often, that the patient, if you're talking about sudden death to the patient and you transmit doubts to the patient, and the doubt is that you are asymptomatic, you are at very low risk, you have no what low risk means, and now with new circulation paper, the group that was saying that asymptomatics were having more events, and now they have 1.1% events per year during the next 10 years. So this, you transmit that to the patient and you say, well, and then of course I have no test to go further in risk stratification because I don't trust some EP study, then 95% of the patients that's for the defibrillator. That's normal. Because you're transmitting doubts and you're saying that you can die. And the incentive, which I think is the wrong way of approaching it. And I know that in the US, implanting defibrillators is much easier, let's say, the decision to implant a defibrillator is much easier than in Europe. I still believe that the EP test, the negative EP test helps you in reassuring the patient and saying you do not need to defibrillator. Although, of course, you might have a patient having some death, of course, but the probability is low. So I guess that this allows you to identify at least 2/3 of the patients that will not need an implantable defibrillator, and you can reassure them not having the defibrillator. I think this is the main point of the technology. I don't want to go further with that because it's an endless discussion.
Yeah. There are now a newer type of defibrillator, the subcutaneous defibrillator. Hopefully they will be of a smaller in size. I think those may be practical and helpful for pediatric and maybe adult as well.
I don't think that now are useful for pediatrics because of the size. I think they will be useful for channelopathies requiring an ICD because I'm convinced that these allow or will allow you. So you don't need to page, you don't need to do antitachycardic pacing, which simply EF termination, which is basically channelopathies. I think that it is going to be useful, but if I would have to implant myself a defibrillator today, I would certainly not implant myself a subcutaneous ICD. The probability of inappropriate therapies is very high. The shocks are extremely violent, and the device is very big. So I'm not sure I will do that. Let's continue with this, and then we go to you because it was from the subcutaneous defibrillator. You want to make some comments?
Just very briefly, I echo your comments about pediatric patients. We have used them in a few less than 5 pediatric patients with channelopathies that were on the bigger end, which is really the substrate that you want. But if your substrate is reentry, not reentry that's unstable like torsades, but monomorphic VT, then a subcutaneous ICD is probably not the right thing to do because antitachycardia pacing is very helpful, and the monomorphic VTs tend to be a lot more hemodynamically stable too, not requiring shock. So there's a role for it. Hopefully they're smaller, so I can use them in the channelopathy patients, which would be great. But right now, I don't think they're ready for pediatric prime time.
Please.
In type 1 manifested cases who are asymptomatic, asymptomatic always has to be taken with a big pinch of salt in this group of patients because, as Nidal said, first presentation could be the final one, or the only one. But nonetheless, in those asymptomatic patients, we can see that electrophysiology can decide, but what is it really at the molecular and genetic level that makes some patients symptomatic and other patients continue to be asymptomatic?
That's a philosophical discussion. I don't know. Why in the same family you have patients that have a similar ECG and one patient has symptoms and the other does not have symptoms? Why in the family we have the females with long PR interval and normal ECG and the males with ST signal elevation having the same mutation? Why in some families having the same mutation someone's expressed as a persistent ST signal elevation and others require actual test to reduce? We don't know. I think probably these are all that we have to talk about modifying factors, modifying genetic effect, combining mutations, combining basic guys will have more questions or more answers than we do on that. I think I would say just to make it easier, that's a biological variability, biological changes, and that means that each one of us is different, and that's very difficult to have a homogeneous group of patients. Yeah.
I mean, the question arises in all cardiovascular disease. Why some patients remain with atherosclerotic disease, never have an MI, the others have an MI. But at molecular genetic level, not at the level of risk factors. But it's important in the sense that if we get into that, maybe we could genetically modify in such a way that patients may not need an ICD in the future.
Well, that was what I was asking to all the patients, to help us in that and know exactly what we'll be in the future able to do so or not. I've been always surprised by or astonished by the fact that how are we going, we can certainly change the channel in a specific cell. How are we going to transport that to all the cells of the heart, and how is this going to be changing all our DNA information? I don't know. This is futuristic, and I don't have the answer. Yeah, I think it was a question there.
Maybe Christian, you want to talk first?
Yeah, maybe I will at least try to say something about the possibilities of basic research. What we learned, I think, the last 2 days was it's not simple. There is not one answer to all the questions and not one method which can reveal all the specific underlying mechanisms. So if you look at the mutation itself, which is in the sodium channel, we might use 3 other mutations which together with it in the cardiac cell, but maybe also the mutation somewhere else. And so that becomes very, very complex maybe, and I don't think we can find any research model which can tackle all these problems. So we will be glad and happy if we find a case where we can, the techniques which are available can really correlate our phenotype, genotype, and then that is a very clear case. Everybody agrees on that. That's so obvious. That can't be. There is no need to explain it differently. Then I think we are very, very happy to do so, and that will give us already evidence for maybe the cases which are not that simple. The use of patient material, stem cells from patient, derive them into cardiomyocytes might help us to see a little bit a bigger picture, but there as well, can we reproduce all the environmental factors which are in the heart existing? Is the maturation we do undergoing the cells, is that the same? There will be always some doubts, but I think at least we can try to find a system which can give us maybe more of the answers which we see now, and then we can decide, okay, IBS cells derived from patients are the better than oocytes at room temperature. I hope that we can develop somehow in that direction, and we can contribute a little bit to the knowledge about the background.
Well, that was what was said. Yeah, well, from a perspective of a researcher, I never see flesh in my life. The patient I see are rats, guinea pigs, dogs, whatnot. So when the studies that have been performed so far were on myocardial infarction, type of heart failure, and hypertrophic heart failure. So when we studied heart failure, we realized that there is not only one mechanism that is involved, and one big, I would say, one of them is the transfer heterogeneity in the left ventricle. If you take, for instance, my infarction, heart failure from ischemia, we will have epicardium and endocardium that are behaving differently, right? The endocardium is more a third than the epicardium. So the question between your type heart failure with Brugada, I don't know if you have done some study on the transfer heterogeneity of the Brugada syndrome. Sure. So for instance, if you give us heart from a rat that has Brugada, I won't look at only one channel. stability, I will look at the biofilm sensitivity, I will look at negative activation, and so on and so forth. So we do a lot of study on one single cell for like 20 years, and at the end of 20 years, we come to the MDs and we give them the results, and that might help some patients.
Sure, there are the whole theory on how the ECG occurs and how arrhythmias occur are not taken from single cells, from particular preparations, and where the role of the endocannabinoid is studied, and the different cells across the myocardium are studied, and how these cells, the end cells, protect the myocardium or the myocardium from the end. For sure, there are
So
also.
when you do glazing, when you do your implants,
Yeah.
you have specific spots where you implant your electrodes, or
No,
you just
no.
put them?
The electrode is a very rude thing. We just give it a shock. That's it. So that's why I was explaining that is a very rude way of treating patients. We are treating not. We are simply treating the consequences of the disease, but we are not treating anything. We are not curing it. The patient has ventricular fibrillation, we give a shock. Period. That's it. And we can give a shock externally, internally, with subcutaneous, non-subcutaneous, whatever. But we give a shock. Period. That's it. That's a big shock in the heart to reset the electricity of the heart and start all over again. So very rude, very primitive, and non-intelligent, but very effective.
Just a brief comment on your question. So I think it is impossible to cure monogenetic channelopathies because each of those mutations cause different effect. So some cause a shift of that, some a shift of that, some that. So I think it's impossible to find a drug that can cure or rescue this effect. And I also think that the pharmaceutical industry is not very much interested in developing drugs for a family. I think they are more interested in finding the trigger for the event. So, I don't know, Brugada syndrome, you suddenly die at the age of 40 or I don't know, 30, but 30 years, the heart beats sometimes more, right? So, and this is probably the same in other channelopathies. So the pharmaceutical industry, as far as I understand, is interested in this trigger for the event. And the triggers may be the same in all the channelopathies, but we don't know yet. But to understand this, you have to understand first the basic mechanism, how mutation alters the action potential and so on. So I think we will never have a personalized drug for one channelopathy, something like that.
Say never.
I think it's very expensive, and so at least, okay, maybe 100 years, but it will be, even gene therapy will be very expensive in my opinion. But the trigger, that is an important point. Another thing is, for instance, the hormone level in females or males, it's probably different, right? So, and Brugada syndrome, male is at high risk. And Asia abuse with the endocrinology, so there could be something which is not discovered yet that could be useful. Or favor, for instance, is such an example. But the pharmaceutical industry, as far as I know, is interested in finding the trigger.
Okay. So, well, I think it's a good way to finish this session. We know a lot, but there is still a lot to learn. Yeah, that was very good. Yeah.
Just I would like to say one thing. Basically, going back to asymptomatic patient with type 1 Brugada, you indicated in your presentation in the EP study the control is negative, and with Ajmaline, for example, it is positive. You could induce ventricular fibrillation during Ajmaline, while during control it is negative. You consider this result as negative EP study?
I say that this has happened once or twice in all my life. I say that this is extremely exceptional.
Okay, let's take it to the real life, and this is where I would like to emphasize on educating patients with Brugada type 1, because they are prone, they are accessible to get over-the-counter medication. This is an example. Exactly, we can mimic the same model in practice, where Brugada type 1 asymptomatic patient, they take drug from over the counter, which could create the worsening with the channelopathy, and they can have a ventricular arrhythmic event. So I would like to emphasize here that educating patients about the type of medication they should not be taken, and to their family physician, because this is really one of the crucial role of having an event, and it could be the final one.
Sure, absolutely. Absolutely necessary to teach them all of that, to learn them all of that, and the fever treatment. So thank you very much. So I think, Professor, it's your time.